excited to have our AGS highlights, and we have 4 different presentations today. Mira and Thomas are going to go first, so I'm going to let them plan to share their information, share their PowerPoints, but we're very excited to have these presentations. So each will be about 8 minutes, either showing a poster or slides, and then we'll have time for questions and comments. So for participants, broadly speaking, both panelists as well as listeners, please chat in the Q&A. So please use the Q&A to add comments and questions, and I will moderate. So I'm very pleased to introduce Mira Melton and Thomas Johnson, who are graduating fellows, 3 more weeks. We're very excited for you. So please, as you present, share a little bit about what's next for you, as well as your title, and then into your presentation. I'll let you know when we have 1-minute warning, but we'll be pretty informal. Thanks.
Great, I'm just gonna share this with everyone here. So hi everyone, I'm Mira Melton. I'm one of the current fellows. And after fellowship, I'll be taking a nice little rest over the summer and then starting with UC Health up in Greeley, Colorado. And I'm really looking forward to bringing some geriatrics up there. And Thomas, you want to introduce yourself too, and then we'll dive in.
All right, and I'm Thomas Johnson. I'm the other fellow. I'll be staying on at the seniors clinic at the university and doing a little bit of time at the VA as well, in Lone Tree location. So you'll keep seeing me around.
Awesome. Well, thank you all for the opportunity to share a little bit about the QI project we worked on this year at the VA and that we presented at AGS. Which we titled The Use of Design Thinking for System Redesign of Home Health Medication Management for Elderly Veterans. This is a project that both Thomas and I worked on along with Sandra Malakauskas, Carolyn Hornay, and Sarah Beck, all over at the VA. Here's our poster for Ease on Your Eyes. This morning, we're going to just break it into a few slides. So as far as background goes, it was brought to our attention by Dr. Malakauskas that we had a lot of patients getting skilled home health services for medication management. And we weren't quite sure who those patients were, what needs they had. And she also brought to our attention that it's very costly to the VA. So for every 2-month recertification, it was costing around $2,000 per patient, which adds up pretty quickly when you have a lot of veterans. So our project dove into looking at understanding the patient population that was getting enrolled in home health medication management, primarily in our geriatric Geripact clinic, and then also to utilize a virtual design thinking process with a multidisciplinary team to try to redesign what this medication management process looks like. So we started out by performing a chart review for our geriatric clinic patients that had active skilled home health orders. We then presented that data from our chart review to a multidisciplinary team and then did a structured virtual design thinking workshop. We then needed to reassess how well that went, and so sent out a survey with Likert scale responses to the participants to kind of evaluate engagement and effectiveness of that process, and then had several follow-up sessions to refine the proposed process. So our chart review is kind of interesting. We looked at the patients, the average age of patients receiving this home health med management were 83. They lived, within 22 miles of the VA on average, but that really was quite broad. We looked at their CAN score, which is a measure of complexity, looking at all their comorbidities, and 94% had a CAN score greater than 90, which is pretty high risk, and then 36% had caregivers in the home. We also looked at their home health enrollment history. So I think the key here is that we looked back 2 years and the average duration of the home health order, or 3 years, sorry, and the average duration of the home health order was like 29 months. So once people started getting this order for home health med management, it wasn't being stopped, and they needed this continued service. We also dove in and looked at their medications. So most patients were on at least 10 medications, and about half of them were on a high-risk medication. And here are some of the high-risk medical diagnoses that we identified for the patients as well. So dementia was high, diabetes, heart failure, or mood disorders, CKD, and others. So after that, we put together a virtual design thinking workshop, which Thomas is going to dive in and talk about.
Yeah, so this basically at this point, Dr. Melton, I believe, came up with the idea to have, instead of a traditional meeting, do a design thinking session, which is something both of us were interested in. And the reason we did that was we saw that this was a multidisciplinary problem and required a multidisciplinary, diverse perspective solution. In traditional meetings, we noticed that oftentimes the power players in the group and the leaders of the group often get what they envision completed, and that's exactly how it goes. Design thinking attempts to break down those barriers. And so we did a couple steps with this group. We gathered a multidisciplinary team of various individuals throughout the VA system who had very different perspectives. This may have been pharmacists. We had nurses from different clinics. We had people who were more on the business side of the VA. All these different people that had different perspectives of how this process was run. And instead of presenting the problem in our proposed solution, we took a different approach and attempted to have everyone come up with this solution together. So design thinking normally is done in person. There's like lots of pipe cleaners, cutouts, things like that. And the purpose of it is to use creativity to rapidly come up with ideas, to test those ideas, and then make modifications through rapid cycles through the design process. That is very hard to do over a virtual session, and we were both kind of novices in this to begin with anyway. So this is one of our first iterations through the design cycle. I think this is Dr. Melton's drawing sheeted. So basically, we had everybody individually take out a piece of paper and draw out how they perceived the process currently went. And it was really cool because we had our perspective, but we saw things that looked totally different than what we thought. Mira, we can move on to the next slide. And so we went through this process a couple times to see the current status quo and what a proposed direction for where we could go with a potential solution to our problem. And to summarize briefly, people really enjoyed the design workshop. They had a great time. They thought it was more effective. They felt more engaged, and they felt the interprofessional group was better represented in the design workshop rather than in traditional meetings. And they also felt like they could participate, and they were very creative. So this is the current process, which I don't know how much time we have to dive into it.
Yeah, so we ultimately, over multiple iterations, came up with this process, which Dr. Beck is now taking forward to try to see if we can actually get this funded. But the concept is essentially a provider would identify the need for help for medications. They're going to put a consult in for a direct to vet med box assistance, which is our kind of creative name for it. And then we're going to try to employ what's called an intermediate care technician. So it's someone who has experience in healthcare, and but they're a little bit less expensive than getting like an actual nurse or provider to go out to the home. And so they're actually going to perform a pre-screen, go out, do a home visit, set up pill counts, do a video to the medical provider, and then they'll work with pharmacy to kind of realign all the med refills. And then they can do either follow-up visits to see how the process is working and either teach a caregiver to take over, either have pharmacy just mail the meds that are already in a pill box and ready to go, or if they're really high complexity and risk, the ICT would actually continue to check in with that patient. And we're also involving occupational therapy in this process. I think the kind of current state of where things are overall with this project is Dr. Beck is now having people kind of look at our numbers and how we came up with them. We put together some financial modeling a little bit to support our project, and showing that we could, save, with just doing this with geriatric patients alone, probably save about $300,000 in the first year, and then over time into the millions. So hopefully this will move forward. And I think overall our takeaway is that using this kind of multidisciplinary design thinking was a fun and effective way to improve engagement and creativity in redesigning a process. And we'll take any questions at this point.
Thank you, and appreciate, yes, leave your poster up so that people can reflect on it. Welcome anyone to chat in questions. I'll ask the first one. So in using the design thinking process, were there any surprises that came out of the process and your engagement compared to if you two had gone into a room and mapped out what you thought would be best?
Yes. I think one of the biggest things, actually, this picture that was drawn, when the picture was drawn while everyone was telling me what happens. So in the right-hand top corner, there's this whole thing about what happens after the consult goes in that the home health group works on. So about 40 minutes per patient on average is spent just like coordinating this process, like processing, calling the home health companies, getting something set up that I didn't even know existed at all. So we found both, a place to save time, but also understood more of that complexity. Any other ones that you saw, Thomas, with your group?
Yeah, I think also as we went through the process, seeing how it was kind of interesting, just seeing how unwieldy our design got over time because of all these perspectives. And then we had to all step back and be like, okay, what's something that makes sense that we can actually pilot? And it was really nice having the perspective of some of the more business-minded folks, because they were like, okay, this is a lot of things going on. Let's really slim this down so that we can actually make a program out of this.
Excellent. Really great project. Love seeing the VA highlighted, and especially a multidisciplinary process, and a process that is available to veterans, isn't widely available outside of the VA. And yet, if this can be optimized well, is hopefully something that could be scaled outside of the VA, like many models have been. So thanks for your presentation. Really appreciate it. We will pass next to Adrienne Brungart as our next presenter, and she will share her poster, walk us through. Adrienne is part of our Living with Dementia program at UC Health Seniors Clinic. So go ahead and show in presenter mode.
There we go. All right, how does that look?
Yes, excellent.
Okay, great. Well, good morning, everyone. As Hillary mentioned, I'm a senior PRA for the division, and I'm also part of the Living Well with Dementia program at Seniors Clinic, which I'll go into a little bit more through this poster. So we're looking at end-of-life experiences within a dementia support program during the COVID-19 pandemic. So persons with dementia and their caregivers have been uniquely impacted by COVID-19, including a higher risk of mortality for persons with dementia compared to older adults without dementia. And they've also experienced significant disruptions to long-term services and supports. Healthcare systems have increasingly implemented evidence-based dementia support programs for persons with dementia and their caregivers. So here at UC Health Seniors Clinic, we are one of several sites across the country adapting a multidisciplinary dementia caregiver support program called Care Ecosystem. So within that program, as we were actively engaging with the families of our patients with dementia during COVID, we wanted to learn more about the context and circumstances of deaths of persons with dementia, not just at our site, but at other sites as well. So for this project, we collected de-identified retrospective data on decedents from the University of California, San Francisco, Ochsner Health in Louisiana, and then here at our local Seniors Clinic program. Within all sites, the program model includes a care team navigator, or CTN, which is a staff member who's the primary contact for the caregiver patient dyads. And we're usually in contact with these families about once a month, so we get to know them pretty well. We asked the CTNs to complete a red cap survey about the decedents, and so that included optional free text responses. And we only collected data on those who died between March 1st of 2020 and February 28th of 2021. So really just capturing that first year of the pandemic so early on. So in that time frame, 29 persons with dementia died across the 3 sites. Almost half were between ages 70 and 79, 12 were women. Majority of caregivers were spouses. And I also wanted to highlight, and I know it's small, I hope maybe you guys can see it, but highlight that most were living in a private residence and died at a private residence. So these were not necessarily nursing home outbreak type of situations. So in the middle, looking at figure 1, cause of death was documented in the EHR for 15 patients. And only 2 deaths were directly related to a COVID-19 infection. And then figure 2 is showing that when we asked the CTNs about their perceived impact of social isolation, they said that they perceived to have a high, that social isolation had a high or very high impact for about 41% of the decedents. Then we analyzed the free text responses. So you can see that column on the right. In that 4 qualitative themes were identified. So isolation due to the pandemic, changes in use of dementia supports and resources, impact on goals of care decisions, and then communication challenges for end-of-life care coordination. And so really highlighting that first quote tells about a woman who did not die directly from a COVID-19 infection, but she had a drastic decline when her spouse could no longer take her for walks or help feed her due to shelter-in-place restrictions when she was living at a nursing home. This demonstrates both a functional decline prior to death from isolation, as well as a physical separation between the dyad partners during the final days of life. We also saw where caregivers then were experiencing unique isolation during bereavement, being unable to coordinate visitation or traditional funeral arrangements. Looking at the theme 2, isn't interesting that the interruption of support services and resources was found both to be not just due to it being unavailability due to mandates or shutdowns, but also caregiver preferences that they wanted to modify or remove some of their supports due to exposure concerns. So for themselves, they saw greater risk than benefit. And then looking at theme 3, when looking at goals of care and transitions of care decisions, is interesting that we saw that perhaps that it helped produce, or COVID and kind of the situation almost helped produce better alignment with patient wishes and for transitions of care or having a procedure, not having a procedure, and kind of this perceived less caregiver guilt of being able to kind of carry out those patient wishes. We only saw 2 out of the 29 died in the hospital. And then looking at theme 4, with communication, it highlighted the complicated nature of communication between team members and agencies, coordinating discharge planning. And this was all, when everything was evolving so quickly, especially early on in the pandemic. So our main conclusion was that COVID had both direct and indirect influences on the context and circumstances of dying for persons with dementia. It also included impact on the care partner's experience of carrying decision-making and bereavement. And through all of this, our goal is that we may be better equipped to respond to the needs of the vulnerable dyads. Any questions?
Yeah, thanks so much. Please do chat in questions in the Q&A. I'll go ahead and ask a question, and maybe even other panelists want to come off mute. Adrian, with this, what could we learn for sort of next very challenging sort of societal level issues that cause widespread disruption? What can we learn from what you've seen in exploring retrospectively these dyads experience that we can carry forward in systems or clinic level approaches?
Mm-hmm. I think one thing I learned was not assuming why something was or was not happening. Whether it was just kind of assumption like, oh, it's shut down, it's not available, kind of thing, versus maybe it was available, but there were fears involved. And so I think I know for myself anyways, moving forward, of being more apt to kind of press into maybe the whys, and maybe there is something that we can alleviate. And also just awareness of the social isolation, I think, was huge. I think for some of the caregivers that I was talking to at that time is interesting, because they're like, well, my world hasn't changed that much because I don't get to go anywhere anyways. But then the other handful, I think, as we all experience, just kind of the impact that it had. You're bombarded with kind of isolation and change. And so just being very aware of how to kind of step into that and how to help, I don't know, come up with solutions or be creative.
Yeah, thanks. Any other questions from panelists? Someday COVID will allow us to be back in our grand rounds room, which will be great. Thank you so much, Adrian. I will transition to the next presentation. I'm presenting on behalf of Dr. Catherine Huber. And so somewhat related to our Living Well with Dementia program in Seniors Clinic, but more broadly, recognizing the gap and opportunity for supporting decision-making for individuals who have dementia, and especially their family care partners, and thinking about anticipatory guidance and how we can prepare for some of the common decisions that happen as individuals need more support. So this poster is titled "More Hands on Deck, Developing a Dementia Decision Support Tool for Care Partners." And I wanna just really acknowledge Catherine Huber, who is a current second year internal medicine resident, as well as other members of our team, and acknowledgement to Dan Matlock, who really gave us an overall framework for how to develop decision aids following what are called the IPDAS guidelines. So I'm sort of going to walk you through a bit of that process, as well as some of the quantitative and qualitative results that we have been gathering over the past year. I also, so that you have a little bit of context, want to take time to show the actual decision aid before we get into the evaluation of it. So I will try to get technology to work in my favor and show this decision support tool. So we have been working on designing this for perhaps about 2 years, again, thinking about what information would be helpful for care partners, especially as the intended audience, to use in the context of a clinic visit or before or afterwards as a resource to think through some of these common questions and different options, including increasing support at home, programs in the community, assisted living, or memory care. And we want, in terms of a decision aid, to raise awareness of what factors a care partner or a family unit might be considering for themselves. So I'll just briefly show you the 8 pages to give you a flavor of this decision aid. We wanted to provide a bit of information about dementia and also highlight the caregiver's role. We, in developing this decision aid, had opportunity to have a lot of stakeholder engagement from patient and family advisors and council members. And this the highlighting of the caregiver's perspective was really informed well by care partner input. This version looks very different than where we started because of wonderful input that we received from many different people. Here's a table with an overview of supports, trying to also include costs and how to find more information. You'll note that this is perhaps very general, not specific, depending on your perspective. In fact, healthcare providers, when we asked them, thought that this information could be more specific. Care partners, in contrast, appreciated that it was a relatively general overview, because in most cases, these were initial thoughts. This was, exploratory information from the care partner's perspective. We wanted to include personal stories, so we have a bit of narrative shown here. We also wanted to have then a step-by-step way of encouraging individuals to consider where they're at, what decisions they might think about, and what the trade-offs or different aspects of those decisions would be, as well as where to get more information. These next couple pages walk through each of the different types of categories: assisted living or memory care, programs in the community. And then we also wanted to end with a place where a care partner could write down their notes and think about what are some decisions or next steps that they want to do now, soon, or later. So with that as an overview of the decision aid, and certainly anyone who's interested, we're happy to share this. We hope to have it posted at a website that is accessible. And then we will also, we're hoping to implement it in routine use in Seniors Clinic. So working on getting back to my PowerPoint without leaving the meeting. So then what we did in terms of evaluation was seek to get input from both care partners as well as Seniors Clinic providers from a multidisciplinary perspective. So we recruited some individuals, especially through the Living Well with Dementia program. It was a convenient sample. We shared the decision aid with them, either mailed to their home or electronically based on their preference. Similarly, the healthcare providers were given a version of it, and then we asked them to review it briefly and then answer a survey related to different topics of what did you think about the content of the information? Did you think it was biased? Did you think you would recommend this to someone else? We also then did sort of think aloud cognitive interviews to have individuals have more of an opportunity to share with us how they thought that this decision aid could be helpful or useful, what they thought about the level of information, and how they could see it being part of a decision. So here in figure 1, you can see how difficult or easy was it to understand the information in the materials. And you can see in the darker color are care partners, and then lighter is providers. So you're seeing general alignment that this was thought to be easy or very easy for these two different stakeholder groups of users. And then moving to just a bit of a summary of the thematic analysis, initially from the providers, we now also have input from the care partners and are moving this forward to a publication. We heard from the providers that they anticipated different outcomes of using this tool. One quote, "I think it would help facilitate more explicit discussions about the types of resources and services and supports available." I already have a lot of conversations, but I think this one, because it's well laid out, sort of puts it into a package, might be a way to focus the discussion. Certainly the tool has some limitations. We heard about perceived value in primary care, and then we also heard just general reactions to it. So we are excited about next steps in terms of the gap that this dementia decision support tool may fill in terms of helping individuals think about different options for more support, either at home or in the community or in a next step in terms of considering residential care. And although this was designed at this point with input from our clinic, from an ambulatory setting, some of our next steps include branching out and thinking about whether this might be helpful by home health team members, such as nurses or social workers who are engaging with individuals, perhaps actually noticing cognitive impairment or functional decline, seeing firsthand perhaps the need for more support. And this might be a tool that could be a bridge toward, can we then have further in-depth conversations and provide you with resources that you could look into for care partners. So with that, I will open it up to any questions or comments from other panelists.
I think one thing that really struck me about this tool was it was like so user-friendly and really well designed. And I was wondering, how was the process of working, if I remember correctly, you guys worked with someone to help design this. How is the process of working with someone else, maybe that's not necessarily healthcare affiliated, to design the tool in such a beautiful way?
Yeah, I think that I've been learning a lot about thinking about how to work with graphic designers and to try to do that in a relatively rapid process. So just like you, Thomas and Mira, explored design thinking as a new method and bringing it into healthcare, I think that the design of tools, trying to think about how to have something be visually acceptable at an appropriate health literacy level, and also working on, communicating a vision, but then not being stuck in sort of our vision, which is, I think, what's helpful about having an external person who specializes in design be able to partner, because then we can be communicating in products that are hopefully more accessible, because they don't seem so designed, just by doctors or healthcare professionals. Let me stop share here. And now I'll transition to Dr. Blomen, and we now have our opportunity to hear about VESPA. Please introduce yourself and share a little bit about what's next for you next year also.
Hi, everyone. Thanks so much. I'm Elizabeth Blumen. I am a third-year resident for like 3 more weeks. And then I will be a Geri Fellow with you all. And yes, so thank you so much for having me. So our poster focuses on the VESPA team, and particularly our collaboration with Cornell in development of our service and our data system. So this was our poster, which I'll break down because it's too small to read. So I think many of you all are aware, but we have an elder abuse consult service now named VESPA.
Let me pause you just a little bit. We are seeing your PowerPoint, not yet your presentation mode. Okay. So it's not advancing.
Oh, I'm so sorry.
That's all right.
Like that, right? How about now?
Yes.
Okay. Great. So sorry about that. So we have developed a consult service here. Cornell also has a consult service, very much based on the model of child abuse protection services, to provide specialty care for these patients. So Cornell's team started in 2017. Our team started in 21. And we focus on providing robust evaluation for these patients in inpatient services and in the emergency room. And then, of course, coordinating those services across healthcare, APS, law enforcement, and whatever other relevant agencies, CDPHE. In New York, there's a host of agencies that they work with as well. And then both of our teams in the last year have really been focusing on following up with patients after they discharge from the hospital to ensure care coordination, that they get plugged back into their primary care medical home, and just kind of help these patients navigate the system. And so part of this team, not only to an opportunity of this team, not only to improve the clinical care, but also gives us a source of data. Elder abuse has really struggled because we don't have great data sources. There's a national APS data system that was just put into place a couple of years ago, but it's not super robust. And so a lot of research has focused on small data systems from either local APS or law enforcement, but there's been no data from healthcare systems themselves. And so this is really an opportunity to get prospective data collected from our cases. And we can really get whatever we would like from a healthcare perspective. And so we are developing this case registry that can then hopefully be used for QI and for research. So we had looked at a couple databases out there in the literature, particularly from the injury world. Tony Rosen and I have worked a lot with the NICE, the National Electronic Injury Surveillance System, which is the CDC database. So we were pretty familiar with that and took pieces from that database. Similarly, the National Trauma Data Bank we've done some work with. And then the Child Abuse Pediatrics Network database, Dan Lindberg, who is our main collaborator here, helped develop that. So our data set is very much informed by those. But then we capture things mostly from the EMR. So all of our data comes from our notes or information available in Epic. And so we get a lot on the initial presentation, what our evaluation was, and the discharge dispositions. And then we are tracking outcomes at 1, 3, 6, 9, and 12 months to see what happens with these. And so because Cornell just recently joined Epic as well, we've actually been able to share note templates and make sure that our data is coming from similar places across our institutions. And then we have frequent collaborative meetings to standardize our review of our data to make sure we're capturing similar things. And right now we have 2 separate databases, but they are both in REDCap, same data dictionaries. So hopefully in the future data could be merged. So some examples of the core data elements collected. So on presentation, we want to know who called us, what were they initially concerned about, who are they calling us about, what do these patients look like, including their functional status is a big proportion of what we are collecting. And then if there's any information on potential perpetrators available, we are collecting that. And then we want to know, what does our team add? So what was on the physical exam, vitals, labs, imaging, things like that, so we can work towards looking more for injury patterns. But also, what do we say, like, what are things that we recommended? Our team often recommends different STI screening or different imaging to look for occult injuries or things like that. So we're tracking that pretty carefully. And then how do we enhance reporting and communication with APS and law enforcement? And then the outcomes that we are particularly interested in tracking right now, although we're hopefully in the next couple of years going to start working more on getting more patient-centered outcomes, but is living situation after hospitalization or subacute rehab. Are there additional services that we've been able to get into the home, and then making sure patients are getting back to their primary. So far our key findings is that we do think that we've gotten pretty good feedback. Our consultation services have been helpful to the teams that have been using us, both for clinical care, but also education. And we are hopeful that for research, this will also improve that outcome. That we've been able to utilize REDCap in a really nice way between our 2 institutions to standardize our data collection and standardize our notes and things that makes this a lot easier. And then also just having 2 referral centers in very different geographic and cultural locations has been really great. Data that was not so relevant in New York is very relevant here, and vice versa. And so I think by having both of those patient populations involved, we've gotten a more enhanced database. So right now we're just using this data mostly for grant reporting and QI, but we are hoping to use it for research in the future. We are continuing to work to refine core data elements for any of these types of teams, and hopeful that if other teams develop, which we hope they will, that this will be a really helpful data system for them as well, and that we'll be able to validate this across other institutions and other patient populations.
Thank you so much. So as you allude to, what additional patient level outcomes would you ideally like to collect? And others, then please chat in questions.
Yeah, we are really hoping to start utilizing something called goal attainment scaling. This is something that probably need to wait until I'm a fellow, which is much closer now. But we are trying to utilize that to identify what do patients and families want in the elder abuse intervention, because often elder abuse interventions are a little paternalistic. It's often like put them in a nursing home, will make them safer, which is not usually what people want. And so trying to figure out what do patients and non-abusing family members want, and how do we kind of respect that dignity of risk and get at more patient-centered.
On a different level, and perhaps from the databases that you've looked into, what's involved in sort of the ethics and legalities of having such database with sensitive information?
Yeah, so Cabinet has worked on this quite a bit. Thankfully, the Child Abuse Research Network, they've been collecting data over, I think Cabinet has been 15 years, but there's been a different child abuse data system going on for about 30 years. Again, it's a lot of just like trying to de-identify as much as possible. And we don't collect a lot of qualitative stuff that would be a little more identifying. So we don't collect like, this is exactly what happened in this location. It's a little bit more quantitative, and we try to kind of like parse it out. So it's a little bit less like identifying and systematic that way. But yeah, that's why right now it is just a database for quality improvement. And then we will be engaging with our IRB to figure out how can we use this for research in a robust way.
Well, thank you so much to all of our presenters. I really appreciate being able to highlight such multidisciplinary, diverse projects across different systems, different topics, different disciplines. We look forward to next year's AGS highlights. So just a plug for all of us to be thinking about what things do we want to move forward to submit in December, so that we can all be together in Long Beach in May for next year's AGS. And with this, thanks for all of us participating in this year's Geriatric Grand Rounds series, and have a great day. Thank you all.